deep tissue and neuromuscular therapy, the extremities. Deep tissue massage is specific, efficient, penetrating, and effective. It uses elbows, fists, and knuckles as tools, addresses the source of pain, yet does not have to be painful.
Hi, my name's Sean Reel. Welcome to my video on deep tissue massage and neuromuscular therapy. This video covers work on the arms and the legs, including the ankle, knee, elbow, wrist, and shoulder. In this video, you'll learn techniques that I found useful in my practice. I've been working and teaching massage since 1990. I work with chiropractors on people who are injured. I've worked with athletes and on people who just like receiving massage. My love is really working with people with injuries. To get the maximum benefit from this video, you should have a good knowledge of anatomical directions. For example, anterior and posterior. To perform excellent massage, a good knowledge of anatomy is essential. To that end, I show the muscles that we'll be working with in the beginning of each section. After this, I show how to assess each structure, and then we'll view the trigger points and the referral patterns. Trigger points are places of hyperirritable tissue that send so many signals to the spinal cord that it becomes overwhelmed and causes the person to feel that the pain is arising from someplace else. Knowing about trigger points is essential in finding the true cause of pain. In this video, we will use 5 types of strokes: stripping strokes, cross-fiber friction, static pressure with movement, and finally stretching.
Stripping strokes are the application of very slow and deep gliding pressure along the length of the muscle fibers. Stripping strokes release and elongate tightened muscle and fascia, flush the muscles with fresh blood, and erase trigger points. Stripping strokes are performed using the elbow, forearm, knuckles, and thumb. The elbow and forearm are used for larger muscles, and the knuckles and thumb are used for detail work and smaller muscles. Cross-fiber friction is usually performed on tendons and ligaments and is done across the grain, so knowing the direction of the fibers is important. Cross-fiber friction creates a healing response in the tissues treated, as well as releases adhesions and helps form healthy scar tissue. Static pressure is applied with fingers or knuckle or even elbow and is an excellent way to release sensitive areas. Static pressure numbs the area, creates a flushing of blood, and helps to eliminate trigger points. We'll add joint movement to static pressure to release the tissues even more deeply. Finally, stretches help to reset the muscle's proprioceptive sense, reminding the muscle that it's now able to lengthen more. Stretching after the massage helps to make the work last longer.
Perform deep massage slowly, or use static pressure in cases of sensitive tissue. Always work within your client's pain tolerance. Deep tissue massage does not have to be painful. Use a scale between 1 and 10, 10 being excruciating and 0 being nothing. The pressure should never be above an 8. The client should be able to stay relaxed while you perform the techniques. If they start to resist or tighten other parts of their body to compensate, then you're going too deep. Any pain should feel good at the same time. An important part of performing good massage is working on the right structure. To this end, we'll use resisted assessment techniques to discover areas of inflammation. To do this, we'll ask our clients to push with 100% of their strength against our resistance. If there is pain or discomfort, then this indicates that the muscles or tendons are strained. If the injury is mild, these tests may not show anything. If it is mild, we can do other things like evaluate range of motion, finding areas of tenderness with our hands, and keep in mind referral pain patterns. With all these techniques, we should be able to rapidly assess the correct tissue to work on. Let's begin.
The shoulder. In this section, we will explore the muscles of the rotator cuff. There are 4 muscles of the rotator cuff: the subscapularis, infraspinatus, teres minor, and the supraspinatus. These are abbreviated in the acronym SITS. In this section, we will also include the biceps tendon, pectoralis major, and deltoid muscle, since these muscles can contribute to shoulder pain. Internal rotators. The subscapularis muscle is underneath the scapula right next to the rib cage. Its action is to internally rotate the humerus. The subscapularis refers pain into the posterior shoulder joint. The anterior deltoid and the pectoralis major also internally rotate the humerus, and will work on them along with the subscapularis. In order to assess the subscapularis, position your client's arm in external rotation and have them push their wrist towards the ceiling. Pain or discomfort indicates inflammation in these muscles. Notice the position the arm lays. With normal range of motion, the wrist should contact the table. Otherwise, there is some restriction in these muscles. In order to work the subscapularis, place the client's hand next to their neck and stabilize their elbow. Move your thumb around the latissimus dorsi and teres major muscles and push in until you can feel the front of the scapula. Apply static thumb pressure and gently move the elbow around. Be careful not to work into the armpit because of the nerves and vessels there. Stay just below it on the edge of the scapula. If they have radiating pain that gets worse with the pressure, move to a different location. Next, place the arm by the side and place the thumb just medial to the head of the humerus. Friction superior to inferior along the line of the humerus on the subscapularis tendon. Do this from 1 to 3 minutes. Next, lay your client's arm in slight external rotation and palm out the pectoralis major, origin to insertion. Then use your elbow to glide inferiorly on top of the anterior deltoid. Lastly, stretch all of these muscles by bringing your client's shoulder off the table, extend and externally rotate the arm, and push their wrist towards the floor. Afterwards, perform the resistance test again. There should be a 70 to 100% abatement of the pain. If this was not the case, then work on the other rotator cuff muscles. External rotators. The infraspinatus muscle lies on the back side of the scapula and is right next to the teres minor. Both these muscles externally rotate the humerus, and we will work on them together. Trigger points in the infraspinatus here refer to the front and side of the shoulder and down the radial side of the arm. Trigger points here refer to the vertebral border of the scapula. In order to assess the infraspinatus, bring your client's arm off the table and have them forcefully externally rotate their arm against your resistance. Any pain indicates inflammation. In order to work on the infraspinatus, stand next to your client and use your thumbs to glide gently from the origin to the insertion with 3 strokes in a fan pattern. Then search for trigger points with your thumb or knuckle. When you find a sensitive spot, hold for 10 to 30 seconds. To friction the infraspinatus tendon, place your client's hand on their back to stretch the tendon. The tendon is located just inferior to the spine of the scapula. Apply cross-fiber friction to the tendon in alignment with the humerus for 1 to 3 minutes. Lastly, use your elbow and glide down the posterior part of the deltoid. Then reassess the group for pain. Abductors. The supraspinatus lies on top of the scapula. Its action is to abduct the arm. In order to assess the supraspinatus, your client abducts their arm against your resistance. It's easy to use your leg. You can also test in this position. Sometimes pain will show up here. If there is any pain, then work on the supraspinatus. To work on the supraspinatus, stand next to their head and use your thumbs to glide laterally on top of the trapezius between the bones of the clavicle and the scapular spine. Next, apply static pressure on top of the supraspinatus while your client abducts and adducts their arm. Alternately, you can do this motion for them. In order to cross-fiber friction the supraspinatus where the muscle meets the tendon, have your client position their arm away from their side in abduction. Place your thumbs between the clavicle and the scapular spine as far lateral as you can. Rotate your thumbs, ceiling to floor. This will cross-fiber the area. Next, use your thumbs to gently twang over the fibers of the lateral deltoid, releasing this muscle. Finally, retest for pain. Biceps tendon. In order to find the biceps tendon, you have to push through the fibrous deltoid muscle. Position the arm in neutral like this. Place the flat of your thumb at a 45-degree angle on the head of the humerus. Rotate the arm back and forth, looking for a groove between two bumps. When you find this groove, friction perpendicular to the humerus on the biceps tendon. Move superior and then inferior, searching for the area of maximum tenderness on this tendon, and then focus your work on that area. The pectoralis minor. The pectoralis minor is located on the anterior torso under the pectoralis major. Trigger points in the pectoralis minor can refer into the chest, shoulder, and ulnar side of the arm. The pectoralis minor can also impinge on the axillary artery and brachial plexus, causing numbness and tingling down the radial aspect of the forearm. This might mimic carpal tunnel pain. To test for neurovascular entrapment, find the radial pulse at the wrist. Then externally rotate and abduct the arm. An obliteration of the pulse indicates entrapment. A tight pectoralis minor will also pull the shoulder forward and inferiorly. With your client supine, the tight side is the side that is raised. Compare both sides. To work on the pectoralis minor, apply static pressure just inferior to the coracoid process. Then cross-fiber friction the rib attachments with your thumbs. Finally, stretch by pushing the shoulder towards the floor. Alternately, use the pectoralis major stretch. Tightness in these muscles go together. After performing these techniques, apply an ice pack to the area for 5 minutes. This will help reduce inflammation. Remember to always retest after the work. In this way, you will know if you have touched the right structure. When you find the exact area, it should only take a few minutes to release it. 2 or 3 short sessions a week for a few weeks are usually enough to help most injuries. We can also test the shoulder with the client standing. Here's the supraspinatus, the subscapularis, and the infraspinatus. The elbow. The two major motions of the elbow are flexion and extension. There are 3 flexors on the anterior side and 2 extensors on the posterior side. Sometimes, however, these 2 muscle groups are not involved in elbow pain at all. Wrist muscles connect to the humerus at the lateral and medial epicondyle, and when they get strained, they can cause pain in the elbow. Racket sports, such as tennis and racquetball, can strain the outside of the elbow. Golf and activities that use the flexor muscles of the wrists can strain the inside of the elbow. We will work on all these muscles. First, let's start with the elbow flexors. There are three muscles of elbow flexion: the biceps, the brachialis, and the brachioradialis. The biceps and the brachialis refer pain into the shoulder and the anterior elbow joint. First, let's perform a resistance test to assess if these muscles are inflamed. Place one hand on your client's shoulder and the other hand by the wrist. Have the client pull their arm towards their shoulder against your resistance. If there's pain or discomfort in the elbow joint, then these muscles are involved. If the pain is felt in the shoulder, then the upper biceps tendon may be inflamed. We'll address the biceps tendon in the shoulder section. In order to release the elbow flexors, first use your palm to glide up the biceps and brachialis. Then apply static palm pressure on the biceps while extending and flexing the elbow. The focus should be the distal end of the biceps, because this is over the belly of the brachialis, and because this is the area that has a tendency to become inflamed. After that, grab the biceps between your finger and thumb and squeeze. If you squeeze close to the bone, you can access the sides of the brachialis. To release the brachioradialis, we will simply apply static compression on the muscle. This muscle can be tender, so use appropriate depth. After performing these techniques, do the resistance test again to assess if your work has helped. If someone experiences pain on the lateral part of their elbow, this can indicate inflammation in the supinator muscle or the wrist extensor muscles at their tendinous attachment to the humerus. This is often called tennis elbow. First, we'll address the wrist extensors. To assess these muscles, have your client forcefully extend their wrist against your resistance. If they feel pain in the wrist, consult the wrist section of this video. To offer relief at the elbow, apply steady cross-fiber thumb strokes in alignment with the humerus over the flexor carpi radialis longus. Next, apply steady cross-fiber thumb strokes over the flexor carpi radialis brevis. This is just distal to the lateral epicondyle. This should be done within the client's pain tolerance for 1 to 3 minutes. Next, let's look at the supinator. The supinator muscle supinates the wrist and wraps around the radius at its proximal end and lies under the brachioradialis. The supinator refers pain into the lateral elbow and the back of the forearm and base of the thumb. In order to test the supinator, grasp the client's hand, then stabilize the wrist with your other hand. Have them forcefully supinate their wrist against your resistance. To work on the supinator, move aside the brachioradialis and find the radius. The supinator lies right over the radius. Then apply static thumb pressure on the supinator while pronating and supinating the wrist. If someone experiences pain on the medial side of their elbow, this can indicate inflammation in the wrist flexor muscles. This is commonly called golfer's elbow. To assess these structures, have your client forcefully flex their wrist against your resistance. If they feel pain in the wrist, consult the wrist section. To offer relief at the elbow, cross-fiber the common flexor attachment at the medial epicondyle of the humerus. Use your thumbs and apply steady, slow strokes for 1 to 3 minutes. If they feel pain in the last 2 fingers while you do this, this means that you're pushing on the ulnar nerve. Move off the nerve by moving your thumb towards the ceiling. There's one main extensor muscle of the elbow that we'll work on, the triceps. The triceps refers pain into the back of the arm, shoulder, and elbow, and also into the lateral aspect of the elbow joint. This mirrors tennis elbow pain, so always check the triceps as well. In order to assess the triceps, have your client push their arm away from their shoulder against your resistance. If there's pain or discomfort, this indicates that the triceps is inflamed. In order to release the triceps, have your client grasp the edge of the table with their hand. You can place your leg against their hand to stabilize it. Then use your thumb to glide from the elbow to the shoulder. Watch out for the ulnar nerve that goes between the olecranon process and the medial epicondyle. Make sure to cover the medial, center, and lateral aspects of the triceps. On the medial aspect, make sure to glide all the way up to the edge of the scapula where the triceps attaches. The wrist, fingers, and thumb. Carpal tunnel syndrome. The carpal tunnel is the space between the carpal bones and the transverse carpal ligament. 9 tendons and the median nerve go through this space. If these tendons become inflamed, they can swell and compress the nerve, causing tingling, pain, or numbness in the fingers and thumb, excluding the little finger. If someone has this exact referral, this is a good indication of carpal tunnel syndrome. Another way to verify this is to apply static pressure over the transverse carpal ligament, compressing the space more. If there is an increase in discomfort, then true carpal tunnel syndrome is a strong possibility. Wrist and hand pain can also originate from the compressed nerves in the neck and shoulder, inflamed forearm muscles and tendons, or strained ligaments in the hand. Often, there is a progression of tension. Tight finger flexor muscles lead to inflamed tendons, and finally to carpal tunnel syndrome. It is not, as is commonly believed, repetitive motion that causes wrist injuries. The body is designed to perform repetitive motion and then to heal during sleep. But if there is unconscious holding and the muscles don't relax at night, then the body is not able to repair itself during sleep. Massage relieves that muscular tension, which then reduces the constant pull on the tendons and allows the swelling to go down and for healing to occur. In order to assess for strained ligaments in the wrist, first get a history. Ask your client when they feel the pain the most. Ligaments are more painful in the morning when they are stiff from the night's immobility. Muscles are more painful at the end of the day after being fatigued through action. After the history, assess. The job of ligaments are to limit the motion at the end range. Assess the ligaments by placing them under stress. Take your client's hand into full extension and then flexion. Pain usually indicates strained ligaments. However, tight muscles sometimes will not allow the joint to fully extend or flex, and the pain may be from the muscles. To eliminate a muscular cause, perform the massage techniques for the wrist flexors and extensors, and then retest. If the muscles were the initial cause of pain, the pain should now be reduced by 70 to 100%. If, however, the pain level is the same, then the ligaments are probably strained. There are about 20 muscles in the forearm that move the hand. We can organize these muscles by the joints that they move: the wrist joint, the finger joints, and the thumb joints. Each of these joints has 2 major motions, flexion and extension. All the flexors are located on the anterior forearm, and all the extensors are on the posterior forearm. This makes 6 muscle groups to work with, 3 joints times 2 actions. There are 2 other major motions that we can perform, twisting motions called supination and pronation. There are muscles that do each of these motions. Don't become overwhelmed by all the muscle groups. We will perform basically the same techniques on each group. First, we'll use our thumbs to glide over the area, warming and softening it. Then we'll apply static pressure using our fist, knuckle, or thumbs while the client moves their joints. And finally, we'll perform a stretch. Keep in mind the simple format as we go through these muscles. Wrist flexors. Focus on the area in blue. There are 3 muscles of wrist flexion, all arising from the common flexor tendon at the medial epicondyle of the humerus, the flexor carpi radialis, palmaris longus, and the flexor carpi ulnaris. The flexor carpi radialis refers pain into the center of the wrist, right over the carpal tunnel. The flexor carpi ulnaris refers pain over the medial aspect of the wrist near its attachment. To test the wrist flexors, Have your client forcefully flex their wrist against your resistance. Discomfort indicates inflammation in the wrist flexors, and massage could help. If there is pain in the elbow with this test, then cross-fiber friction these muscle attachments at the elbow, as shown in the elbow section. To work the wrist flexors, glide from the wrist to the medial epicondyle with your thumb. Focus your attention over the belly of the wrist flexors. Next, apply static pressure with your fist while your client flexes and extends their wrist. Alternately, use your thumbs. Another option is to passively flex and extend your client's wrist as you apply pressure. This is an extremely effective way to release the muscles. Finally, stretch the wrist flexors. Don't perform this stretch in the presence of strained wrist ligaments. Strained ligaments are indicated when there is pain on passive flexion or extension at the end range. Finger flexors. Focus on the area in blue. There are two muscles of finger flexion, the flexor digitorum superficialis, shown here, and the flexor digitorum profundus, underneath. Each muscle has 4 tendons, and all 8 of these tendons go through the carpal tunnel. These are the tendons most likely responsible for true carpal tunnel syndrome, so releasing these muscles is of prime importance. The flexor digitorum superficialis refers pain into the fingers, but can also be involved in dull wrist and forearm pain. In order to test the finger flexors, position your client's wrist in neutral and have them flex their fingers against your resistance. To get an accurate test, make sure the client only uses their finger muscles. To work the finger flexors, strip these muscles with your thumb. Remember where these muscles are and work directly over them. Next, apply static pressure on the belly of the finger flexors with your fist while your client flexes and extends their fingers. You should feel the muscle moving underneath your fist. Alternately, use your thumbs to apply pressure. Another option is to passively flex and extend your client's fingers while you apply pressure. Finally, stretch the finger flexors by fully extending the fingers.
You've just finished working on the wrist and finger flexors. Even if someone just has anterior wrist pain, you also want to work on the wrist and finger extensors on the back side. And the reason is because joints work with opposing muscle groups. And if you loosen up one side, the tightness on the back side may pull the joint out of balance, and what will happen is the body will naturally tighten the flexors back up again. So when you're working on any joint, in any joint in the body, always work on both sides, and that'll allow the joint to become neutral and for the work you do to stay.
Wrist extensors. Focus on the area in blue. There are 3 muscles of wrist extension, the extensor carpi radialis longus, brevis, and extensor carpi ulnaris. We will focus on the 2 extensor carpi radialis muscles, which can refer pain into the posterior wrist. In order to test the wrist extensors, the client will extend their wrist towards their elbow. If there is pain in the elbow, refer to the elbow section of this video. In order to work on the wrist extensors, first apply slow, deep thumb strokes on top of the muscles. Then apply static pressure with your thumbs while your client flexes and extends their wrist. You should be able to feel the muscles move under your thumbs. Alternately, you can use your fist. Another option is to passively flex and extend the client's wrist. Finally, stretch the wrist extensors in the absence of ligament strain. Finger extensors. Focus on the area in blue. The main muscle of finger extension is the extensor digitorum. This muscle can refer pain into the fingers and cause stiffness in the finger joints. To test the finger extensors, stabilize the wrist, make contact on your client's proximal interphalangeal joints, and have them push their fingers into extension against your resistance. To work the finger extensors, strip from the wrist out to the lateral epicondyle with slow, deep pressure. Then apply static thumb pressure into the belly of the finger extensors while the client flexes and extends their fingers and wrist. Moving the wrist helps increase the muscle motion. Finally, stretch by curling your client's fingers into a fist and flexing the wrist. Performing massage can really stress the thumbs. Here are some tips on how to use your thumbs properly while giving a massage. Keep your joints aligned as much as possible so that the bones will transfer the force rather than the muscles. This means the wrists are close to neutral and the fingers are bent to allow the thumbs to contact the tissue. Stay away from circling your thumbs under pressure. Loading your thumb joint and moving through its full range is a sure way to injure the joint. Instead, the power stroke should be a straight adduction flexion like this. This uses the large muscles of the thenar eminence and is easy for the joint. When applying static pressure, align the thumb joints by pressing your thumbs into your fingers at this crease. Also keep the wrist joint in neutral. One leg is back, one leg forward, with your elbows locked. This allows the force to come from the ground and to be transferred through your bones, not your ligaments or muscles. Remember that no one body part can take the focus of an entire session, so switch techniques often. Use your elbow, forearm, fist, or knuckles. Let's look at the thumbs. Thumb extensors and abductors. Focus on the area in blue. There are two muscles of thumb extension, extensor pollicis longus and brevis. We will also include abductor pollicis longus because anatomically it lies right next to the brevis and because it's easy to work on these muscles together. In order to test the thumb extensor muscles, have your client extend their thumb against your resistance. To work on the thumb extensor muscles, use your thumb to strip just inside the radius, client's palm down. Also, strip right over the radius where the thumb muscles cross it. Next, apply static thumb pressure on the thumb extensors while your client circumducts their thumb. To stretch these muscles, curl the thumb under and ulnar deviate the wrist like this. Thumb flexors. Focus on the area in blue. The main muscles of thumb flexion are the flexor pollicis longus and the group of short thumb flexors and adductors in the hand. The flexor pollicis longus refers pain into the thumb and can be involved in dull wrist and forearm pain. It is commonly strained in massage therapists. In order to test the flexor pollicis longus, have your client bring just the tip of their thumb towards their elbow against your resistance. To work on the thumb flexors, position your client's palm up. Then use your thumb to slowly strip up the inside of the radius. Next, apply static thumb pressure just inside the radius while the client flexes and extends the tip of their thumb. If your thumbs are hurt themselves, you can always use a knuckle instead. In order to release the short thumb flexors, glide from the base of the thumb towards the palm. Then apply static pressure at the base of the palm while your client touches their thumb to the base of their little finger. In order to stretch the thumb, bring it into full extension. The last two motions of the wrist are supination and pronation. We've already covered the supinator in the elbow section, so now we'll look at the pronator. Pronator. When working on the pronator, focus on the area in blue. There are two muscles of pronation, the pronator teres and the pronator quadratus. We will focus on the pronator teres, which refers pain down the forearm and deep into the radial side of the wrist. To test the pronator, grasp your client's hand, then stabilize the wrist with your other hand. Have the client forcefully pronate against your resistance. To work the pronator, apply static pressure on the belly of the pronator while pronating and supinating the wrist. Here's the anterior forearm. The wrist flexors, the finger flexors, the thumb flexors, the supinator, and the pronator. Here's the posterior arm. The wrist extensors, the finger extensors, and the thumb abductors and extensors. Now I'll review the arm work from the perspective of self-massage. Assess your wrist for ligament strain. Then use your other forearm to glide out the arm. Use your palm as the resistance for the resisted assessments and assess the wrist flexors, finger flexors, and thumb flexors. Then apply pressure over the wrist flexors while flexing and extending the wrist. Next, the finger flexors while moving the fingers. Then, the thumb flexors with thumb movement. Now, find the supinator and supinate and pronate the wrist. Then move over a little onto the pronator and supinate and pronate the wrist. Next, test the wrist extensors, finger extensors, and thumb extensors. Then glide out the arm with the opposite elbow. Pinch the wrist extensors and flex and extend the wrist. Then apply deep finger pressure while flexing and extending the fingers and the wrist. Finally, apply pressure while you circumduct the thumb. To complete, we'll stretch the wrist and finger flexors together, then the wrist extensors, and then curl the fingers under for the finger extensors. Finally, the thumb extensors and thumb flexors. This routine will help most wrist pain. If there is still pain with the wrist stretches or assessments, this is a good indication of ligament strain, which can take a while to heal. The ankle. Ankle everters and ankle sprains. The muscles involved in ankle sprains are the peroneus brevis and to a lesser degree the peroneus longus. The peroneus brevis can refer pain into the lateral ankle. There are also two ligaments commonly involved in ankle sprains, the calcaneofibular and the talofibular. Only work on these ligaments after the initial inflammatory stage when the swelling has gone down. To work on these structures, position your client's ankle across their opposite leg, then use your elbow to glide up the peroneus longus and brevis. Then apply static pressure with your thumbs over the peroneus brevis. Next, cross-fiber friction the talofibular ligament just anterior to the lateral malleolus. Then cross-fiber friction the calcaneofibular ligament, just inferior to the lateral malleolus. Finally, reposition the client's leg and standing at the base of the table, glide up the foot flexor muscles just posterior to the tibia. These muscles can be very sore. Ankle plantar flexors and Achilles tendinitis. There are two muscles involved in plantar flexion, the soleus and the gastrocnemius. Both these muscles connect to the calcaneus via the Achilles tendon, which can become inflamed. Trigger points in the soleus can refer pain into the calcaneus. Start by frictioning the Achilles tendon. Put the tendon on a stretch by placing the foot against your belly, then grasp your fingers under the ankle and use your thumb to roll across the sides of the Achilles tendon. Next, release the foot from your belly and use one thumb to push aside the tendon. Then rotate your other hand in order to cross-fiber the anterior part of the Achilles tendon. Make sure the rotary motion is across the fibers of the tendon, not along with them like this. Perform the same technique on the other side, pushing the tendon over and frictioning the anterior side of the tendon. Remember, pressure is towards the ceiling. This work can be intense, but is highly effective. Always work within your client's pain tolerance. In order to work on the soleus and gastrocnemius, glide with your forearm up the leg. Place no pressure on the posterior knee. Next, use your thumbs to split the heads of the gastrocnemius. Then apply static thumb pressure on the lateral edge of the soleus, where it has a tendency to be sore. Now, search for trigger points in the soleus that refer to the calcaneus. Finally, stretch the soleus by bending the client's leg and placing the foot on your chest, or you can use your hands or elbow. Stretch. The knee. In the knee section, we will divide the knee into four parts. The center of the knee, the cruciate ligaments, the knee extensors, anterior knee pain, medial and lateral knee pain, and then the flexors and posterior knee pain. The center of the knee. The anterior and posterior cruciate ligaments run diagonal inside the knee and stop the tibia from shifting forward or back. To assess the posterior cruciate ligament, bend the knee, sit on the foot. Place your palms on the tibia near the knee and forcefully shear it posterior. To test the anterior cruciate ligament, cross your fingers under the calf and forcefully pull towards yourself. If there is pain or discomfort, then there is inflammation in one of these ligaments. We can't do much for these ligaments because we can't touch them, but we can put them on slack and hopefully reduce the inflammation. If these ligaments are severely strained, surgery might be the only answer. To relieve pull on the anterior cruciate ligament, push the tibia in the opposite direction that we tested. Push the tibia posterior and hold this position for 2 to 3 minutes. This should feel good to the client and offer almost immediate relief. To release the posterior cruciate ligament, pull the tibia forward by grasping around the gastrocnemius and steadily pulling anterior for 2 to 3 minutes. Knee extensors and anterior knee pain. There are 4 muscles that extend the knee: the vastus medialis, the vastus lateralis, the vastus intermedius, and the rectus femoris. The vastus medialis refers pain into the anterior and medial aspect of the knee. This trigger point in the rectus femoris also refers to the anterior knee. For anterior knee pain, we'll address the infrapatellar ligament and the coronary ligament. Then we'll release the vastus medialis, rectus femoris, and vastus intermedius. To help the infrapatellar ligament, stabilize the patella and with your other hand perform cross-fiber thumb strokes where the ligament meets the bone. Search for the place of maximum tenderness and do this from 1 to 3 minutes. For the coronary ligament, bend the knee, then cross the fingers behind the knee and use your thumbs to press down on top of the tibial plateau on both sides of the infrapatellar ligament. Friction horizontally for 1 to 3 minutes. This ligament helps to hold the meniscus in place. To work the muscles, first glide up the rectus femoris with your forearm. Then use your thumbs to push aside the rectus femoris, focusing on top of the vastus intermedius. Then do the same thing on the other side of the rectus femoris. Next, change the angle of your forearm and glide up the vastus medialis. Then, use your fingers to friction across the fibers of the vastus medialis at its most distal point. Next, apply static pressure. Now, use your thumbs to search for the trigger point in the most superior part of the rectus femoris. Finally, stretch with the client prone by fully flexing the knee. Medial and lateral knee pain. In this section, we will address the medial and lateral collateral ligaments, the iliotibial band, and the vastus lateralis muscle, which can refer pain into the lateral knee. Medial knee. For medial knee pain, assess the medial collateral ligament by stabilizing the lower leg and pushing on the outside of the knee, which will strain the medial collateral ligament. If there is pain or discomfort, friction this ligament by finding the joint space, then moving posterior until you feel a strap across that space. Then friction anterior to posterior for 1 to 3 minutes. After this, perform the techniques for the vastus medialis, shown in the anterior knee section just seen. Lateral knee. In order to assess the lateral collateral ligament, stabilize the lower leg, hook your fingers under the knee to the opposite side, and pull the knee towards yourself. If there is pain on the outside, then this ligament is inflamed. To friction the lateral collateral ligament, find the joint space and follow it posteriorly until you feel a strap crossing the joint space. Friction here, anterior to posterior, for 1 to 3 minutes. Position yourself on your knees and use your forearm to glide up the vastus lateralis. Alternately, you can position your client in side posture and glide up the vastus lateralis like this. Then, in side posture, we'll friction the distal 2/3 of the iliotibial band with our thumbs. Posterior knee. There are 5 muscles involved in posterior knee pain: the popliteus, the gastrocnemius, the biceps femoris, the semimembranosus, and the semitendinosus. Trigger points in the biceps femoris refer pain into the posterior knee, as do trigger points in the gastrocnemius and popliteus. First, glide with your forearm up the entire posterior leg, missing the popliteal space behind the knee. Next, work the second head of the biceps by gliding up the thigh at an angle. Then, bend the knee and rest the ankle on your thigh. Find the medial hamstring tendon and move down across the popliteal space. Apply static thumb pressure here over the medial head of the gastrocnemius. If you feel a strong pulse, move inferior or more medial. This point is often tender. Next, find the lateral hamstring tendon, move down below the knee crease, and apply static pressure on the lateral head of the gastrocnemius. To work the popliteus, use your inside hand, wrap your fingers around the tibia, and use your thumb to push aside the gastrocnemius and apply pressure onto the posterior part of the tibia right over the popliteus. To stretch, clientis supine. Bend the hip and knee to 90 degrees. Stabilize the thigh with your hand, and then slowly extend the knee using your shoulder. Normal range is approaching a straight leg.
This video covers a lot of information. Watch it once and practice it on your clients, and then come back and watch it again. I'm sure you'll find an added depth to it. I really enjoyed making this video. Thank you for watching, and I hope it helps your practice.